I suggest we get started. Welcome to our session, Reaching Men, Yes We Can. My name is Godfrey Musuka. I'm Country Director for ICAP at Columbia University in Zimbabwe. I'm going to be co-chairing this session. We have 5 exciting presentations from a number of countries. I will hand you over to my colleague Helen so that she takes us through the first 3 presentations.
Thank you. Yes, good morning. My name's Helen Ailes. I'm a researcher from Zambia, not from Zimbabwe, as it says in the program, but from Zambia. And our format today is we're going to hear from the speakers. And what we're going to do is give a little bit of time for questions, particularly for clarification, or questions you may have to each speaker after each speaker speaks. And then hopefully we'll have a bit of time for discussion at the end. So if we move on to our first speaker. Our first speaker is Kelvin Ndede, who's from Kenya. He's the technical advisor for M&E at ICAP Kenya, and he's going to talk about multiple disease screening to destigmatize HIV testing and increase identification of persons living with HIV in Kisumu, Kenya. So Kelvin, the floor is yours.
So, thank you. It's a privilege to make this presentation in this conference on behalf of ICAP team. The title of my presentation is Multi-Disease Screening to Destigmatize HIV Testing and Increase Identification of people living with HIV in Kisumu, Kenya. So this is the outline of my presentation. We look at HIV country context, progress towards the first 90 in Kenya, ICAP innovation towards bridging that gap, the results of our innovation, and finally, our conclusion, recommendations, and suggested next steps. So Kenya is one of the countries with a high HIV burden. It's ranked 4th largest HIV epidemic in the world, alongside Mozambique and Uganda, with a prevalence of 6% and about 1.5 million people living with HIV. So there are regional differences in the HIV incidence. We have about 8 counties out of the 47 counties contributing 51% of new infection. Now, ICAP supports HIV prevention and treatment services at a national teaching and referral hospital within Kisumu County. So Kisumu County has a prevalence of 19.3%, which is 3rd highest in Kenya. According to our 2016 clinical cascade for Kenya, women are almost hitting the first 90 at 89%, but there's a gap for men at 67%, and also for the youth at 48%. Now, so this is despite the rapid scale-up in HIV testing within the country over the last few years. So according to the last survey that was done in 2012, of course we are waiting for the FIA results, but according to that survey, only 63% of men had ever tested for HIV. So we had about 30% of men who were to be targeted for HIV testing and awareness. So based on this gap, ICAP started a multi-disease screening program in March 2017, offering a package of wellness services that include screening for TB disease, hypertension, obesity, and HIV testing. So 4 booths were set up at a hospital entrance, and the clients, both patients and non-patients, aged 15 years and above, were eligible to access services within the 4 booths. And the services were advertised by banners, posters, and flyers as free services. Now, the healthcare workers were trained on multi-disease screening using national guidelines and deployed to deliver multi-disease screening alongside HIV testing. M&D tools were developed. Job aids, SOPs, were developed and rolled out in line with the multi-disease screening. And then a referral system was established between the multi-disease screening program and the points of service within the hospital and outside the hospital. So this is a summary of the wellness package at the multi-disease screening. So we have nutritional assessment, blood pressure assessment, HIV testing, and linkage for those who are diagnosed with HIV, TB screening, blood pressure assessment, and then, of course, referrals. So we analyzed routine data collected from these booths, and these are our findings. So during the review period, we had a total of 6,236 clients who presented at the multi-disease screening centers. All of them were screened for multi-disease, and including HIV, and 95% of them were found eligible for HIV testing. So all the eligible clients were tested for HIV, and 113 were newly diagnosed with HIV, translating to a positivity yield of 1.9. And out of those who identified positive, 75% were linked to HIV care. Now, disaggregating HIV testing uptake by gender and age. So majority of the clients who were tested for HIV at the multi-disease screening booths were male at 54%, and then most of them were old, the age category above 25 years. Now, we disaggregated further by age, and then, of course, looking at the uptake, comparing the uptake with other points of service. So at the multi-disease screening, we saw 54% of men. At the inpatient wards, we had 46% of men. And then at the outpatient clinics, we had 45% of men. Now, among the older clients who presented, among the older men who presented, you saw that majority of them actually were seen at the booth. Now, we also compared positivity yield from the different points of service. So multi-disease screening centers yielded 1.9%. Inpatient wards yielded 2.0%. And then at the outpatient clinics, we saw 1.7%. So this might not be significantly different, but it's an interesting pattern to see that the yield within the multi-disease is more or less similar to what we are seeing at the outpatient clinics. So since we provide services at extended hours, also we go beyond the normal working hours in the evening and over the weekend. And I think it is interesting to note that during the evening, 57%, among those clients who presented in the evening, 57% were men. Among those who presented over the weekend, 52% were men. And then among those who presented during the weekday, 53% were men. So proportionately, we saw more men than women at these booths, regardless of the time. And so these are some of the multi-disease screening outcomes for the BMI and the blood pressure. So this is an added value for the multi-disease screening. So 70% had normal BMI. We had 16% overweight, 10% underweight, 4% obese. And then for blood pressure, 78% were within the normal range, 16% pre-hypertension, and then 6% grade 1. So they were screened and referred for services appropriately. Now, in conclusion, so we see that providing HIV testing and counseling within a multi-disease screening service is an innovative approach to reach men who do not routinely seek health services. So the extended working hours, especially the evenings, were utilized by men for HIV testing. And then the yield, of course, may not be significantly different, but I think it's important to note that it will be important to note that it's similar to what we are seeing in other points of service. And then the approach was also used to identify clients who had high or low BMI, who had hypertension, and those who had presumptive TB cases, and thereafter referred appropriately. So there's need to do further analysis to characterize clients who seek services at this center, and then also to do a cost analysis for this strategy. I wish to appreciate PEPFAR, CDC, MOH, ICAP team, and the clients. Thank you.
So this paper is now open for questions from the audience, and I'm sure there are some questions. While you're coming to the microphones, maybe I could start off. Kelvin, thank you very much. How did you decide on your package of multi-disease, interventions or screenings? Was that just based on what was available or what people wanted, or how did that get decided on?
Yeah, so the package was determined by what was available at that point, because these are some of the screening services we offer at other points of service. But the booths were set up at the hospital entrance at the gate. So it was easier for them to be aware of those services, because when they come to the hospital to see the patients, they have to wait for the visiting hours at the gate. So it's easy for them to know that these services are available.
So, the lady in the blue, I think you were first. Please introduce yourself.
Hi, I am Sarah van Rompuy, and I work in Mozambique for the NGO Friends in Global Health. I have two questions. The first one is, how was demand created? As it was a new service, how did people know that there was this service offered at the health facility? And secondly, how did the linkage happen to the treatment part, as well as for HIV, positive men or women, as well as hypertension or any other disease? And was there any difference with linkage with the people from that service or the inpatient or outpatient ward in terms of percentage? Thank you.
Yes, so in terms of demand creation, so we came up with the flyers and banners, which indicated clearly that we had free health check services. So we had a banner at the gate, and also we made some flyers that were distributed within the catchment area at the hospital. In terms of linkage, so there are a number of strategies that are being used. So we have individuals who escort clients to the ART clinic. Immediately they are identified positive, so they actually escorted to a retest center, to a retest point of service where they are retested and then cancelled for ART initiation. So there's no difference between the linkage at the booth and within the outpatient and inpatient clinic. Overall, we are seeing a linkage of 79% for the hospital, but this was not very different from what we saw at this booth, of around 75%.
Okay, this lady here.
Thanks for that presentation. My name is Esther. I'm from ECPAF in Lesotho. I just wanted to find out in what way are you incorporating other critical innovations, such as referral for VMMC and PrEP for those who are HIV negative, and for the 15% that you didn't link to treatment, are you doing anything to try and track them? Last question is, are you doing anything about indexing these patients who test positive? Thank you.
Yeah, so this might have missed in my presentation, but these are some of the referrals that happen at this center. So we are doing we assess all clients for PrEP eligibility. So there's a tool that's called a RUST tool that's administered to all the clients, and then those who are eligible for PrEP are actually referred for PrEP. Yeah, and then we do the same thing for VMMC. We also do index testing. For everyone who tests positive is actually listed as an index client, and then they are asked to elicit all their sexual partners who are followed for testing either at the facility, or they are asked to bring their partners. So we have a different set of data for index testing for this particular point of service.
Okay, if the gentleman over here, if we can be quite quick because we're running short of time.
Thank you. Andrew Kambugu, I'm from the IDI at Makerere University in Uganda. Thanks for your talk, Kevin. Short clarification. On the current slide, you talk about number who are eligible for HIV testing. Could you clarify what you mean by eligible?
So we determine eligibility based on a criteria we call expanded eligibility criteria. So it is determined based on when you were last tested and whether you were able to verify the last results. So if you were tested more than 3 months ago, then by default you become eligible for an HIV test.
And the last question, I'm afraid, is going to have to be the gentleman there.
Yeah, Mike St. Louis from CDC in Atlanta and PEPFAR. So this very nice presentation, thank you. We often think of having extended hours and weekends and so on for men, but you had a much higher prevalence, and almost all of your positives were captured during the regular work weekday. And I wonder if you have any reflection on that, any explanation or any thought going forward. Right, so during the weekdays, there's 2.5% and 94 of your total positives. So almost all the yield was during the regular work. Yeah. What do you make of that?
Yeah, so we may not have straight answers for that, but I think, so this is one of the areas we need to take a look at keenly to understand what's really happening to people who come during the extended hours.
Great. Thank you very much indeed, Kelvin. Thank you. So our next presenter is Elizabeth Jeffroy, who is the M&E Manager for the Global AIDS Interfaith Alliance, which implements HIV interventions in Malawi and Liberia. And she's going to talk on cracking the code to increase men's uptake of HIV testing, providing convenient and confidential outreach HIV testing services through mobile clinics. Elizabeth.
Thank you, Helen. Thanks, everyone, for coming today. I'm happy to talk to you today about Gaia's outreach testing for men in Malawi. And first, I just want to declare that I have no conflicts of interest to disclose. I also want to thank the Elizabeth Taylor AIDS Foundation for funding of this project. First, I'll give you a brief background on the HIV epidemic in Malawi, and then I will talk about Gaia's mobile health clinic model and how we use that in an innovative way to reach more men with HIV testing services in Malawi. So Malawi is on track to meet the UNAIDS 90-90-90 treatment targets, and as was outlined in the FIA study in 2016, the largest gap in the HIV treatment cascade currently is in HIV testing. The report put out by UNAIDS last week, Miles to Go, showed that much progress has been made in Malawi in terms of HIV testing. However, men still lag far behind women. Only 67% of men in Malawi living with HIV, age 15 to 64, know their status, compared with 76% of women of the same age. Here's a map of Malawi, and it shows that HIV prevalence is very different depending on geographic area in the country. Nationally, 9.6% of adults in Malawi are HIV positive. However, in Mulanje district, in the southern region of Malawi where Gaia works and where the program I'm going to talk about today is located, 21% of adults are living with HIV. Gaia has been operating a weekday mobile basic healthcare program in southern Malawi since 2008 with funding from the Elizabeth Taylor AIDS Foundation. We currently have 7 mobile clinics reaching 2 districts and serving an area that covers almost 1 million people. These clinics are operated by a clinical officer, a nurse aide, and a driver. And we also have a follow-up coordinator who is a nurse traveling by motorbike to follow up with any clients testing positive or any clients needing home-based care. At these clinics, HIV testing is integrated into other basic healthcare services. We noticed that from 2009 to 2013 that there was a sustained gap in the number of men that we were treating or testing for HIV. As you can see in the chart here, the red bars represent the number of women we were testing each year, and the blue bars represent the number of men we were testing each year. And what we saw is that in 2011, 2012, we were testing only 1 man for every 5 women we were seeing at these clinics. And then oftentimes, or almost always, men were testing positive at a higher rate than women. And that can be seen by the blue line and the red line. This means that the men that were coming into the clinics were already generally quite sick and suffering from other co-infections. Our mobile clinics were generally deemed as female spaces. They weren't necessarily friendly to men. The majority of the clients that came to our clinics were women and children, and the majority of our healthcare providers were female. So we wanted to figure out how we could better attract men to HIV testing services in the districts that we were working in. So we conducted a formative evaluation in 2014 in partnership with the University of California, San Francisco, to better understand what the barriers and facilitators for HTS were for men in Mulanje District. This was a qualitative study involving 30 men, including both villagers and village opinion leaders. And the interviews centered around 3 main questions, including how have you been affected by HIV, what have you heard about HIV testing, and what would make you more likely to get tested. The result of that study was the development of this health behavior model for men in our area. The barriers to testing that were identified are very similar to barriers to men's testing in other areas, namely lack of awareness about HIV, anticipated stigma that men felt when they self-identified for testing or were to be found positive, they may be discriminated in their communities, and concerns about confidentiality of testing results. They also identified several facilitators to testing, namely male-targeted messages and opportunities for testing. At that time, and even still today, there are far fewer opportunities that reach out to men for testing compared with, say, adolescent girls and young women. They also identified opt-out testing as a way to potentially reach more men, as well as convenience of testing in terms of both time of events, but also location of events. And there was this interesting interaction between concerns about confidentiality and not wanting to get tested close to their homes, but also wanting testing to be very convenient. So based on the results of those studies, we held community sensitization meetings with both men and village opinion leaders to inform them about HIV testing, and provide them with information about new opportunities that were going to be coming for men to be tested in the district. We also employed male HTS counselors and ensured confidentiality by rotating counselors and ensuring the counselors didn't come from the same area that the men were being tested. And then we went ahead and implemented convenient weekend testing events targeting men and their sexual partners and children. To implement the program, we used the same mobile clinic vehicles that were operating during the weekdays on the weekends and some of the same staff. We partnered with the Mulanje District Health Office, which was vital to the program, to identify underserved areas or high-risk areas within the district that we could target for men's services. And we engaged large employers like tea estate owners to offer opportunities to test their workers on site. We also engaged community opinion leaders and faith leaders, like I mentioned, to encourage testing within their communities. And then we conducted HTS at 3 main sites. The first one being work sites, which again, as I mentioned, were primarily tea estates, construction sites, and markets. The second group of sites were community-based sites, which were primarily schools, community centers, and other health facilities, but with an area specific for the men to come, as well as places of worship, like churches and mosques, holding events after weekend services where lots of men were. We collected data using a mobile data collection app so that we could use real-time data to see which sites had high yields or were high risk and target those for additional testing events. This is a testing event that we held at a primary school. You can see the vast majority, I think there's only one woman in this picture, but the vast majority were men, and men of all different ages. So, since 2014, we've held over 100 male targeting testing events. We've tested over 6,100 people, of which 71% were men. And what you can see in the chart, the men are represented in the blue bars and the number of women testing are represented in the red bars. And that over time, both the number of men we're able to reach with these events as well as the percentage of men coming to the events increased. And then the yield did decrease slightly for men over time, as you can see in the blue line. And we asked men, why did you choose to come to get tested today, for everyone who came? And the most commonly cited reasons for coming to this event to get tested were the convenience of location, publicity or community sensitization surrounding the event, and convenience of time. Across all age groups, we tested 30% who had never previously been tested before and may not otherwise have been tested if they were not reached out to in this way. Overall, 3% of men were found positive. In this chart, the bright red part of each column represents men that had never been tested before. The dark red section of each column represents men that had been tested before. So if we look at particular age groups, we see that young men, aged 15 to 24, made up the majority of those that we tested, which means that this was acceptable to that age group. Overall, in that age group, 42% had not previously been tested. And though we had a lower yield rate of 1.2% among that age group, it was an important venue to provide prevention services so that they could hopefully stay negative. For men over age 25, only 20% had not previously been tested, but we did see a much higher yield at 5%. The highest yields were among those aged 25 to 49. And finally, I wanted to show the percentage of men testing positive by previous testing status as well as targeted event location. So for community sites, we did not really see a difference in the number of men testing positive. Again, here the blue bar shows the yield for all men, and the red bar shows the yield for first-time testers. At religious sites, we saw a slightly higher yield, with 4% of all men testing positive and 5% of first-time testers testing positive. And then work sites, we saw many more men testing positive, with 8% of all men testing positive and 12% of those tested for the first time testing positive. Referrals. All of those testing positive were referred for confirmatory testing, and once Test and Treat was implemented in Malawi in 2016, we also referred them directly for ART initiation and encouraged them to ensure their partners and their children sought testing either at our normal weekday clinics or at a future event or a local health facility. All men testing negative were referred for voluntary medical male circumcision and other prevention services. So what we learned is that young men and first-time testers were effectively able to be reached through mobile male-targeted testing. However, community sensitization and providing convenient services was critical to improving uptake of testing among men. We were able to use real-time data as well to assess high-risk areas in need of testing so we could improve targeting and program performance and provide more events in areas where risk was high. This program was expanded in March of 2018. We now have 2 clinics holding 10 events every week in the highest risk areas, particularly like male work sites. These clinics are also providing integrated services, so not just HIV testing, but also other disease screening. And we are now linking testing data with treatment initiation and adherence data at the district level, which we did not do previously. And we're planning to hold family testing events where men can come with their families to be tested together or direct families and sexual partners to come for testing and counseling as well. I also want to acknowledge the role of the Mulanje District Health Office, which is instrumental to this program and achieving these results. And thanks again to the Elizabeth Taylor AIDS Foundation and all of our Malawi staff who made the program possible. Thank you.
Okay, so this paper is now open for questions. I see somebody coming to the microphone there, so carry on.
Hello, hi, thank you. My name is Kerry Johnson with PSI Zimbabwe. Thank you for your presentation. let me just, I don't normally stand up and make those comments to everybody, but I'm just going to comment, and then maybe if you could help me. So the first comment is, since 2016, I've been going to these missing men presentations, and I'm an epidemiologist by training, and one of the things that I think that we're really, really missing is the characterization of these men when we call them the missing men. And it's emerging for me as kind of a big stickler, again, as an epidemiologist and as a program implementer. So I was just wondering, on the one hand, so for example, I really appreciate that you're tailoring your services, you want to reach these folks, you've reached them in a variety of settings, but then you're only disaggregating them just by age and maybe where you're trying to reach them, and then your yield is actually rather low. I mean, I appreciate the specificity of service delivery, I love it, but I think that perhaps, and if you could comment on this, I think that by not characterizing maybe the characteristics, the identities, and the behaviors of these specific men, and that includes, like, of course, men who have sex with women, men who have sex with men, trans feminine men, I think that we're maybe missing the nuances and the targeting that we possibly could achieve. And I was just wondering if maybe in your experience or the lessons learned, if you could think about or comment on how, well, we got a 3% yield, but we found if we really did this, we would get a higher yield. Thanks.
Thank you so much for that question. It's a really important question. And we know from other survey data that there is a high HIV prevalence among MSM, specifically in Mulanje district. We think the prevalence is over 25%, so it's an important thing to think about. Men are not self-identifying as gay or having sex with men, but it's definitely something we've included in this new expansion of our program. It's part of the risk assessment. We do see few men self-identifying, and so it's an area we definitely need to work on to reach out to these other populations who may not be comfortable accessing these types of services and could be better accessed or better served through something like self-testing. So definitely something to think about. Thank you for that comment. Oh, and then you had one other comment about yields. We're definitely seeing lower yields than we would see at our weekday mobile health clinics. We think that's definitely because the men that were coming to the weekday clinics were already quite sick and needed to come for testing, whereas we're able to reach more well men through this targeted program and hopefully get them onto treatment before they start becoming sick. Thank you.
Great. Yes, the lady at this microphone, and then we'll...
Yes, hello. Thank you so much for your presentation. It was excellent. My name is Maria Carrasco, and I work for USAID. My question is about a little bit related to prevention and the value of, or the potential use of HIV testing for prevention. You mentioned that 30% of the males that you reach have not been previously tested. So can you speak a little bit about, how your testing services maybe would be, helping with prevention? And also a little bit about the linkage that you did of the men to VMMC and perhaps to any other prevention services. Again, what's the potential of testing for prevention? Thank you.
Yes, thank you very much for the question. We did link men to VMMC when there was availability of those services in the district. We also provided them education about general HIV testing and the benefits of that in terms of prevention. PrEP is not widely available in Malawi at this time, so we did not recommend that for the clients, but we did offer them other preventative services, and we do think that getting these younger men, which we did see a lot of, into testing, making it part of a routine healthcare services for them will hopefully make them more comfortable and more willing to come in for these services in the future.
Great. And the last question, and if you could try and keep it short because we're out of time.
Okay, fine. Thank you very much for the presentation. My name is Webster Mavo from Sisha, Zimbabwe. One thing we have found with other interventions with men is that once you follow them at home, you heighten the stigma. So although we are reaching them, we may also be worsening the stigmatization. Thank you.
Thanks for that comment. It's really important. And our follow-up coordinators that follow people coming from the weekday mobile clinics are not only following up with HIV positive people, but also others suffering from other severe conditions, so that it's hopefully not identifying necessarily people that are being followed up at home as HIV positive, but just someone needing further care. I forgot the second part of the question, but thank you.
Thank you. Okay, our next speaker is Dr. Megan Dunbar, who is a gender and HIV prevention expert. and she's going to be talking to us on engaging young men in healthcare and HIV testing, the Shaz Hub Youth Drop-In Centre. The floor is yours.
Great. Good morning, everyone, and thanks, Helen and Godfrey, for the opportunity to be here today. I'm going to be talking to you today about the Shaz Hub, which is a youth drop-in center and clinic located in Chitangwiza, Zimbabwe, and a kind of story that we have about engaging men, young men, adolescent boys and young men in our health services and other services that we offer through the hub. So first to say that I have no conflicts of interest to disclose. And just to set the stage, I think there's been a lot of discussion at this conference about the need to engage adolescent boys and young men in health services and in HIV prevention. And in fact, that was highlighted yesterday with the launch of MenStar and the coalition that is really going to be, focusing on better engaging young men in the future. And I think this is in part kind of evolving out of the fact that a lot of HIV programming has recently focused on adolescent girls and young women, and for really good reasons, given the increased vulnerability of young women to HIV and all of the other, economic and structural inequities that we know young women face. However, I think we're beginning to realize as a field that there are these critical gaps in meeting the needs of adolescent boys and young men who are much less likely to seek health services than adolescent girls and young women or adults, including those for HIV testing and HIV prevention services. Young men are often diagnosed late for HIV and show up at health clinics with advanced disease. And there's a burgeoning understanding that some of this may be related to sort of masculinities that are internalized that suggest that seeking health services or prevention services are really kind of conflated with the idea of feeling weak or being perceived as weak. And so there's a need to sort of try to figure out how to better reach young men in this context. So I'm going to talk a little bit about the Shaz Hub, which is a youth drop-in center and clinic, as I mentioned, in Chitangwiza, Zimbabwe. And it was established really as a research site focused on trying to understand the vulnerabilities of young women and girls. In 2016, we opened up the Shaz Clinic to be a broad youth drop-in center. And what we discovered is that as soon as we opened our doors, we had a large influx of young men who were coming to access the services. And so in terms of just the service delivery data that we were tracking during this time, we saw that from July 1, 2016 through June 1, 2018, that among the almost 3,000 clients that we were seeing, that 63% were male. And this is without having done really anything to specifically attract or sort of create demand for these services. For example, our staff was entirely female. We didn't do anything really specifically to sort of attract young men per se. So when we discovered this, we really decided that we wanted to understand it better. But first I want to tell you a little bit about what we do at the Hub. So the Hub provides comprehensive sexual health and HIV services to young people aged 16 to 24. In addition to the health services, we offer life skills education, which is really a series of group-related educational activities focused on sexual and reproductive health. And we do job training, and this is actually a picture of some of that work where we do short trainings on how to create small businesses around candle making and things like that to generate a bit of income. We provide counseling and peer support. We have a couple of peer navigators who help with linkage to care and also adherence for those who are HIV positive and on treatment. And we also offer recreational activities. There's a TV that's attached to satellite TV. There's Wi-Fi. There's a common space where people can hang out and play games. And so, we have all that sort of on offer at the Hub. As I mentioned, it began as a research clinic focusing on young women and evolved into this broader drop-in center. And it is the current site for research focusing on the potential of social media messaging to increase services uptake. And while I'm not going to be talking about that study because it's in progress and we're still waiting for the results of that study, it is the umbrella under which this qualitative research that we did was housed. So a little bit about service utilization during this period that I mentioned among all of the clients attending the hub. Just to again point out that during that period, more than half, the 63%, were male, and that most of the youth attending the clinic and accessing services were in the 16 to 19-year-old range. In other words, the younger kind of proportion of the clients that we serve. The majority of services, or the services that the young people were mostly trying to access was for HIV testing, and also some related to pregnancy prevention and minor ailments. So the question that we wanted to answer is, why do adolescent boys and young men come to the hub? And so this was really a programmatic research that we engaged in, where we looked at the intake data forms that we collect on a regular basis to try to characterize and understand a little bit more about the young men who were attending the services, and we focused here on the new clients. So what was it about the new clientele that were attending the services at the hub? And in addition, we wanted to do some qualitative research to unpack a little bit what some of the challenges are that young men face when trying to access services generally, and what characteristics about the hub did the adolescent boys and young men who are coming to the hub, what did they find appealing about it? And then also, what could be done in the future, both at the hub and in the public healthcare setting, to improve services for them. So just to go quickly through some of the findings. In terms of our examination of the intake data forms, the kind of basic demographic overview of the young men who are attending the clinic, their mean age was 18. A little bit less than half had been reported having ever engaged in vaginal sex, and even fewer in anal sex. The lifetime number of partners was reported to be 5, and about 50% of them had ever tested for HIV. And then the reasons reported for attending the hub were primarily to get an HIV test and to access the health services for minor pains like a headache or other ailments. And then we asked how they had heard about the hub, and most of this had been through word of mouth. And then they reported from a flyer. So there were outreach activities that were going on in the community where outreach workers would go and try to educate the community about the hub through circulating flyers and sort of talking to individuals on the ground. And then some of the other ways in which they had heard about the hub were through referrals or having walked in and decided to check it out. And then in terms of some of the findings from the qualitative research from the focus group discussions, when we asked why is it that young men, adolescent boys and young men, have such a, what are some of the barriers to accessing services? And really what came out more than anything was the experience that they have with healthcare workers in a lot of the public clinic settings, where they talked a lot about being shouted at by staff or being called sort of derogatory names when they talked about their sexual activity. And so, they would say things like, healthcare workers shout at us, and they say, you have a problem being prostitutes, and then you want to come in here and get tested when you are already sick. And I think this statement really kind of sums it up, that they, the healthcare workers, will be treating you, but ill-treating you at the same time. The other issues that they talked about were a little respect for privacy or confidentiality, where healthcare workers would sort of call them out for being called out when walking into the clinic, and that they would be shy to disclose their sexual behavior because of some of the stigma and kind of the ill treatment that they would be facing when they get in there. They also talked about the cost of services and the long waiting times. And I think really interestingly, they talked about the fact that as boys, they maybe see it as a sign of weakness, that men are supposed to be strong even when they are sick. Some of the things that would compel them to come in for the health services in spite of these barriers were having STI symptoms, a persistent cough, seeing a parent or relative die, needing to get PEP if a condom bursts, erection problems, and advertisements by a local celebrity. So what is it about the hub that was drawing these young men into the service? And I think more than anything, the young men talked about the relationships that they had with the staff and the way that they were treated with respect and also the camaraderie that they had. And so they talked about how the nurses would bring themselves down to their level and help them with their needs. They said they handle us very well and with open arms, and that this nurse was a free person with whom you could crack a joke and laugh. And they allowed the young men to be themselves. They said that even when we are smelling, they don't shout at us. They tell us in a good way that we are smelling. So they just felt comfortable, and they felt like they were allowed to be themselves. And that was one of the primary reasons that they felt comfortable coming. They also talked about enjoying the access to the free services and treatment, and access to Wi-Fi and the video games and the satellite TV. But mainly they said it's a safe space for us, and it's a better place than being on the street where we're hanging out and smoking weed and drinking beer. It makes us feel comfortable to express ourselves and not be judged by anyone. So I know I'm running short on time, so I'm just going to keep going through that. Some of their recommendations for how this could be integrated into the public health clinics is primarily and above all, healthcare workers should be trained to treat us with respect. They again highlighted their interest in having services maybe geared towards them that would be free or at low cost, and that there would be suggestion boxes at the clinics that could be taken up and that could be dealt with when they raise critical concerns. So in conclusion, while it may not be feasible to replicate every aspect of the Shaz Hub model, it does seem like there are low-cost ways to integrate some of this. For example, maybe offering some of these services for free or at low cost, creating separate and confidential spaces, above all, sensitizing healthcare workers, and offering recreational activities when and as possible. But I guess I want to say that all of this should be done, but not in any way at the expense of attending to the needs of adolescent girls and young women. And I think that this actually offers an opportunity to bring young men into the system and also to use that as an opportunity to further attend to and deal with issues of gender inequality and the need for ongoing work to create safe spaces for all young people. So with that, I'd like to thank my collaborators and, of course, above all, the staff and the clients at the Shaz Hub. Thank you very much.
Thank you, Megan. There is time for question or anything for clarification. Just while waiting for that, Megan, do you offer, you mentioned that there were services for treating minor ailments, but are there other services at the hub for treatment or prevention?
Yes, so we offer the full range of HIV testing. The clinic does do screening for STIs and treatment for STIs, but it is syndromic management, based on the guidelines in the country. Because we're housed at the Chiringuiza City Med Hospital, we do link any adolescents who test positive with HIV to the ARV clinic there, so they get treatment there and then follow-up services from the hub. And we've also very recently started offering oral PrEP as well.
I think we've got time for one question because we're sort of out of time, but let's have this lady at the front maybe.
Thank you very much. I'm Justine from Lesotho. My question is actually related to STI. In view of the high yield of STIs amongst the clinic beneficiaries, 100% of those screened, why haven't you considered providing routine STI screening for all the beneficiaries as part of the minimum service package?
I'm sorry, could you repeat the second part of the question?
Why haven't you provided routine STI screening for all the beneficiaries in the clinic?
We would love to offer STI screening as part of, the basic level of services in terms of STI diagnostics. It's a matter of resources that we do not actually have the capacity. It's a clinic that's housed within a public health setting. So what we do is offer anyone who has a concern or who has questions or would like to, to have their health assessed in that way. We do offer that, but because of the lack of resources, we're not able to sort of offer diagnostic screening for anyone who or for as a kind of comprehensive service as part of the package.
Okay. Thank you so much, Megan. I think maybe we need to move on to the next presenter. I think we can give a clap. Yeah. The next presenter is Dr. Michelle Rowland. She's the country director for CDC in Botswana. She's going to be presenting on home-based testing identifiers more previous undiagnosed older men than mobile testing in Botswana. Over to you.
Good morning, and thank you everyone for being here. I know there are a lot of interesting sessions going on right now, and thanks very much to the organizers for giving us the opportunity to talk about our experience identifying previously undiagnosed older men using home-based testing in comparison to mobile testing in Botswana. The Botswana Combination Prevention Project, or BCPP, was funded by PEPFAR, and I have no conflicts of interest. In Botswana, UNAIDS estimates that approximately 85% of HIV-positive individuals currently know their status. As countries throughout the region start to approach the UNAIDS 90-90-90 or even 95-95-95 targets, it becomes increasingly challenging and increasingly more important to ensure that we're employing the most effective HIV testing strategies to be able to reach those people who remain undiagnosed across all ages and sexes. The BCPP study was a randomized controlled trial in 30 matched rural or semi-urban communities in Botswana. The intervention communities, 15 of them, received mobile and home testing strategies between October 2013 and September 2017. The main outcome for this particular analysis is new HIV-positive persons identified using those different testing approaches. In this presentation, in the 15 intervention communities, we'll describe HIV prevalence. We'll skip that second bullet. We'll also be looking at the newly identified HIV-positive community residents by age, sex, and testing approach, and cost estimates per test and new diagnosis by testing approach. So let's start with the findings with regard to prevalence by age and sex in the study. The purple-ish bars represent females, and the green bars represent the males. You can see that the overall prevalence was 21.5% in this population in the 15 intervention communities. Among females, it was 26.3% and peaked at almost 50% among females aged 35 to 44. Among males, the prevalence was 15.6%, peaking at 40% in the 45 to 54 age group. BCPP tested 48,825 individuals and identified 2,036 new HIV-positive individuals for a yield of 4.2%. You can see that 25,000 females were tested and about 1,000 diagnosed, 23,000 males tested and about almost 1,000 diagnosed. So there were similar numbers of males and females who were diagnosed in the study. We next looked at the proportion of new positives among all positives. So 15% of all of the HIV positive persons identified in BCPP were newly diagnosed, with quite a range of the proportion of positives who were newly diagnosed across the age and sex groups. So let's look at the new HIV positive testing yield among those 2,036 individuals I told you had been newly diagnosed across the 8 age and sex categories that are demonstrated here. So first in purple, we see the females. The highest proportion of new diagnoses was among the 35 to 44-year-old age group with a yield of 6.2%. And to the right in green, we see the males with a similar pattern, the highest proportion of new diagnoses among the 35 to 44-year-old age group, this time higher than the females at 8.1%. Now let's shift our focus to try to understand what was happening with the home-based testing strategy in the first 2 rows and the mobile testing strategy in the bottom 2 rows among the females and males. So home testing represented 46% of the total tests, yet it yielded slightly higher, 54% of the new positives. Among the 22,601 individuals tested in the home, we found 1,105, or 4.9%, were HIV positive, in contrast to the 3.6% of new HIV diagnoses with mobile testing. And that was a statistically significant difference. So again, let's look at the home and mobile testing approaches across the 8 different age and sex categories and try to understand that pattern. It's a similar pattern where home testing yielded proportionally more new diagnoses among the 35 to 44-year-olds. Among the females, you can see 123 new diagnoses with a 7% yield compared to a 5.1% yield for mobile testing. And among the males, 164 in that 35 to 44-year-old age group with a yield of 11.2%, again, substantially higher than the 6.3% yield for males 35 to 44 tested with mobile testing. Finally, let's think a little bit about what it costs to be able to employ these 2 different testing approaches. So the cost per person assessed with mobile and home-based testing was quite similar, $36 and $34. But not surprisingly, the cost per person tested after they were assessed for eligibility for testing was a bit higher for the home-based strategy. There were more people who were not eligible for testing who had to be screened before individuals who were eligible for testing were identified. And likewise, the cost per new diagnosis was higher for home-based testing at $1,284 compared to the $975 for mobile testing. This analysis did take into account repeat testers and those who already knew their HIV status but had not disclosed it. So in conclusion, in this rural and semi-urban Botswana population, the new diagnosis testing yield generally increased with age and was highest among males aged 35 to 44. The proportion of new diagnoses was also highest with the home testing strategy compared to the mobile testing strategy. Therefore, targeted home testing remains important for identifying HIV-infected men and women in a country like Botswana with relatively high first 90 or first 95 coverage. We heard this morning from Dr. Kalonzo from Kenya about how they're using this more granular data approach to target differentiated prevention services. Likewise, we feel that these kinds of granular data may be useful to select a mix of testing approaches that is specific to the first 95 gap across age and sex groups within local geographic areas. And of course, the relative cost per new diagnosis must also be accounted for in the design of testing approaches. So finally, I'd like to appreciate a lot of people, the BCPP study participants and site staff, our Ministry of Health and Wellness collaborators, many collaborators at CDC, at Botswana Harvard Project, and at the Harvard School of Public Health and our implementing partners. Thank you very much.
Thank you. We will take 2 or 3 quick questions as people come up. Maybe let me ask my question. I'm just asking myself, did you include those remote communities that are in the Sandveld? We know that these are areas where individuals are left behind in many ways in the Sandveld, the Kalahari region of Botswana. Thank you.
In the Kalahari region, I am going to ask Jan Moore if she's here. Are you here, Jan? I think she just snuck out. I will have to get back to you on that. I'm not seeing the map in my head clearly enough to be able to respond. You don't think so?
No, I don't think.
Yeah, I don't think so.
Right. Okay, thank you. You can go ahead.
Thank you very much for the insightful presentation. My name is Anita Mondo from PSI Zimbabwe. And I just wanted to find out, we're trying to follow the home-based testing strategy following our contacts of HIV-positive clients home. I wanted to understand, as you tested this home-based strategy, how were you doing it in the community? Was there any targeting of certain households at all? How did you deal? Is it an issue to do with stigma in the community? How were you moving from one household to the next? Was there any targeting in that?
In the initial phases of the study, as best I understand it, and I'm representing BCPP coming in a little bit late into the process, initially the home-based testing was a blanket approach. So it was kind of similar to the SEARCH study where they were trying to do everything that they could to find every single person in the community through a combination of mobile and home testing. The initial findings in the first phase of the study suggested that they weren't finding the same proportion of individuals in the home that they had expected to find. They were finding a higher proportion with the mobile testing. So they started to take a more targeted approach in identifying which homes they should be approaching for testing later in the study. And they did end up finding a lot more people with that more targeted approach.
Florian Neuhan, University Heidelberg, Germany. Thanks for your presentation. I was curious to actually, how did you get access to the houses? It's a follow-up on that, like the permission to go to the homes, and what was really the difference, which did not become clear to me, between the mobile, how mobile and how close to the homes was the mobile testing as compared to directly go into the homes, and the question of how did you get the permit to visit the people at home? Thanks.
Again, I apologize that I don't have enough of the programmatic experience to be able to give you that detail, but those of you who are interested, if you talk to me afterwards, I can connect you with those who are closer to it. I will just end by saying that there's a qualitative sub-study that the Harvard colleagues have conducted and will be getting ready to publish soon that demonstrated that a lot of people really appreciated the home-based services. So I think that was also a helpful component.
We'll take the last question.
Mine actually is a question to all those who presented.
Is it possible maybe for us to take that at the end?
At the end?
Yeah, at the end. We still have one more speaker, so we can still give you the opportunity to ask later. Thank you so much, Michelle. Our last speaker is Tabiso Alphonse Lekotla. He is an adolescents and priority populations technical advisor with the Ministry of Health in Lesotho.
Okay, thank you very much. Maybe just to correct it, I'm not from Ministry of Health Lesotho. I'm from Elizabeth Glaser Pediatric Gates Foundation Lesotho, supporting Ministry of Health. So I'll be taking you through the male engagement works to improve HIV services uptake among men. So like some other previous questions, presentation indicated that we have a challenge of reaching men. So for us, we say, yes, we can reach them through our initiative. So I'll be presenting on behalf of the core of us. I don't have a conflict of interest to disclose. This is just the presentation outline. We have the background and why do we need men's-friendly health clinics and other bullets as indicated. So Lesotho has the second highest prevalence of HIV worldwide, and HIV is the leading cause of death in the country. And this is because we have high prevalence of 25.6% of adults aged 15 to 59, and the high incidence of 52 new HIV infections that occur on a daily basis. And it's believed that older men are the ones who are driving this HIV epidemic among adults and girls and young women. As you can see that from 15 to 49, the incidence for men is 2.1%, and for females is just 1.7. So why do we need the male-friendly health clinics? The answer is yes, because it's because, we can see most females know status more than males, which is 81% of males knowing their HIV status as compared to 71% of HIV-positive men. And men often present very late in advanced disease at clinics, and then we are also experiencing high mortality rates. And men really feel like now when they come to the clinics, they see that the healthcare workers are female service providers, and they don't feel comfortable from being seen by the female service providers. And then they find that the environment at clinic is more women and child friendly. As you can see when you get to the facilities, even if the literacy materials are put on the walls, there's nothing that talks to them as men. So they feel like really this is not the place for us. It's for only pregnant, breastfeeding women and their children. And health facilities provide services only during business hours. And in country, what we have is there is a policy of no work, no pay. So it means if men are at work, they are not able to come to access the services. And also, and now if they are missed going to work because the services have been provided during business hours, it's going to be a challenge for them. So there is no services that are provided for them before work, after work, or over the weekends. And even if the Ministry of Health is trying to ensure that it addresses like promoting accessibility of services, taking services to community, the same challenge exists. Like when you get there, you find the same men, the same people that you see at the facility, which is females and their children, men not there, and they are at work. And men are very, don't like the long lines that they experience at facilities. You know, in country, there's this challenge whereby 100 people just go to facility, all of them in the morning, and at 8 o'clock when the clinic opens, they are all there, 100 of them. But the challenge is that not all of them will be served at 8 when the facility opens. So it means they have to be on the line for a long time, and then some of them lose, men, especially men, they lose patience and leave the facility without being seen. And just also addressing that issue of service providers also being provided by female nurses and female counselors. Some men really indicated that, you know, when you go to facility, especially when you have to give out sensitive issues, is start to now not relax, especially sexually transmitted infections. That means now you have to go below the belt, and they don't feel comfortable to show up what is happening with them to female. So this is ECPAF Friendly Health Service approach. So ECPAF, in collaboration with Ministry of Health, they had to address the mentioned barriers that affect men from accessing the services. So what happens is that they provided dedicated clinic space where men feel comfortable as only men, and meaning they own the space as men. And this place, that's where they were provided with services, meaning it was one-stop shop. They would get services and get their medication, and then we're trying to ensure confidentiality and privacy for them, and then they go home. And also, what is happening, the services are being provided in the morning hours, evening, and also over weekends to ensure that also men who are not able to come during the business hours can come and access services. And then also we provide appointments to reduce long waiting times. This has really been working because, like we said, that all of them, they will come in the morning, but not all of them will be served. So if you have made an appointment We give you a date, we give you a time to be seen. So it was really easy for them, like, I just go to the clinic and I'll just spend less than 1 hour or less than 30 minutes at the clinic and I'm done. So what we did in order to scale up this, to open this clinic, before we could start everything, we did focus group discussions, whereby we went to men and like discuss with them, this is what the package we think that we bring to you to provide services to you. Do you think this package will really answer your needs as men? And they said, yes, this is what we want, please, it will answer our needs. So from then, in June 2017, we opened the clinics. So 7 public high-volume facilities were identified. These clinics are located in high-transit places, whereby men can just access them easily. And then really, these clinics are providing men-friendly services. And then male nurses and male counselors were hired and trained on men-friendly services. This was just going to ensure that, to allow men that when they come to the clinics, they are free and relaxed, especially stop them from, like, if they have STIs, and then when they go into the clinic and see a female nurse that is providing, maybe they start to replicate saying, I'm having headache instead of the real problem. So these are a list of services that are being provided in those clinics. We are really providing comprehensive services, just highlighted some there. And now, community outreaches were conducted through radio programs. Collaboration with the Ministry of Health is the key, because now we had platforms in national radio stations, televisions, where we could just tell people about the services that are being provided and how can they access the services. Also not leaving out index testing, whereby we already know that female partners are there and then they really have their men out there. So we did index testing so that we ensure that they come also and access this, because now maybe if they are not able to come in other in general clinic, know that they have their own corner as men where they can get services freely and comfortably. So this is results that we had. So what we did, we compared data for January to March 2016, and then July to September 2017. So the blue color is for number of men tested before men's clinics, and the orange one is number of men tested after the men's clinics were established. So you can see there's high number of men that were tested after the men's clinic were established. Also, looking at men that tested positively, we still see the good results that after the men's clinics were established, we really have a high number of men that tested positive. So the other good thing that we're happy with is that when we look at men that came to the clinics with non-positive status, we could see that after the men's clinics were established, a lot of men were coming in large numbers. And then we asked them why it really made them not to come and get services before. They really told us that, you know, I'm a working man, and then now, after you are being initiated on art, you are asked to come for follow-up checkups. So it's not easy for me to keep on asking permission from work to come and be reviewed by the service providers. And also now, even at work, when you ask too much to come to the clinics, people start to associate you with HIV and these chronic illnesses. So I don't want to be associated with that as a man. So we are really happy to see them coming, and then now when they see that the services are flexible, now they agree to take treatment. And now we can see that we had a large number of men that were initiated on art. So also, we had Lesotho implemented test and treat in June 2016. So we said, okay, fine, let's compare also in these facilities number of men that were initiated during test and treat, and also compare them with the time when the men's clinics were established. I can tell you that we really saw a large impact of the men's clinic. The graph just goes high, and we're really happy that it shows that really men appreciated this initiative. So, you know, it can do everything, but there are still challenges. So these are some of the few challenges that we have and proposed solutions. There's limited space of dedicated men-only clinic areas. You know, when the Ministry of Health was building clinics, they did not think that they would have what is called men's corner, or men's clinics. So it's really a challenge. Also, there are few male nurses in country. So like men saying that they enjoy being seen by male service providers, so it means it's a challenge if we have few male service providers. Those are the proposed solutions. We have like dedicated days for men at facilities that do not have male nurses. So meaning now this male nurses where we have established clinics, now to replicate this, we'll just visit other clinics where there are no male nurses, just call a day and say, this is a men's clinic day, please come and access your services. Also, we need to have targeted outreaches for demand creation and also increase accessibility of services among hard-to-reach men. There are men that are working in places whereby they cannot even just be allowed to go anywhere. So also want to make it easy, like, okay, fine, why can't you just go there and provide comprehensive services, not just saying HIV services, but all services that men need. And then also MOH to advocate for training of male nurses and counselors, and this is already in pipeline. They are doing that very much, and we are happy for that. So some of the lessons learned is that providing male-focused services is a welcomed initiative among men in Lesotho. This is proved by the numbers that we are seeing of men coming to the clinics. And also, when, like we said, we are going public and in a public or national radio station and televisions, a lot of them do call and tell them, for the first time, Ministry of Health have really managed to recognize us as men and answering our needs. So the number of men tested at health facilities where men's clinics are located has increased since they are established. And also the pre-art men are now accessing art through this men's clinic. So the next steps, we are really happy that the Ministry of Health is really taking the lead out of this. So we are really having a scale-up plan to ensure that now from 7 clinics, now we go, I don't even want to tell you because it's a crazy target, up to 35 men's clinics that we want. And now also we want to increase index testing and partner identification for women on art to help us to identify more men. And also there's a need also to continue training and mentoring male healthcare workers to ensure that this friendliness that they are providing to men should not stop, but it should be replicated. And I would just want to acknowledge PEPFAR, USAID, and then Minister of Health, Deputy Minister of Health for Lesotho, who is here. She is there. Really, we are very much thankful for this initiative to be implemented. Thank you.
Thank you so much, Tabiso. Can we have 2 or 3 quick questions for him? Yeah, we can go ahead.
Hi, good afternoon. Sarah again, Mozambique, Friends in Global Health. Thank you for a nice presentation with very impressive results. I have a question about men who are already on ART in health facilities close by these ones, but not offering male-friendly services. So was there any tendency of men who were transferred out of other health facilities who wanted to subscribe in these health facilities? Thank you.
Thank you very much for this important question. One of the reasons why the Ministry of Health is pushing to scale up these clinics is because now we are seeing a lot of men coming from nearby facilities, even just from other districts, coming to where men's clinics are being established to come and access these friendly services. So we want to stop that by replicating these men's clinics to other things. Like I told you that we have a target of 35 men's clinics that we want to achieve.
You can go ahead.
Thank you so much for the presentation. I'm just curious to know, between the time of testing to when ART services were initiated, what was that time frame?
Can you come again, please?
I'm curious about the time frame between testing, between diagnosis and starting ART.
Okay, thank you very much. Like we said that now we are implementing test and start. So it's men don't decline ART initiation. They are tested and then they are going to be initiated same day. So we are really happy because now their follow-up checkups are now conducive to them. Like, okay, fine, we won't force you to come over the week while we are at work. You can come over weekend. So they are appointed, they are free. Yeah.
Right. The gentleman to my left, and then we go to the back, and then come to the front.
Thank you. Thank you very much for these male dedicated clinics. That's great. So as you're thinking about those clinics, are there any trainings or anything done specifically around these men's, say, sexual risk behavior? Meaning that is the staff sensitized to screen for guys who have sex with men and women, or they may have anal STIs, or the ways that the environment itself may be made to be as welcoming for all men as possible. Thanks.
Thank you very much. Yes, we have a training curriculum that is specifically dedicated for men-friendly services. And yes, we do provide like different men like MSM, and then also screening for STIs. There's a package for that. And we are really happy to share that we have that curriculum.
Yeah, thank you very much, Harriet Bitimwine from Ministry of Health, Uganda. Thank you for that presentation once again. My question is, are you really certainly sure that this great work and the attraction for men and testing for services is centered around the male provider, or it's the package of services that is offered? Is it possible for your program to consider female providers but giving a similar package of services? One of the things we've seen in Uganda, if you go to a salon that has male attendants, it's more likely to attract females, and if it has female attendants, more attractive to the opposite sex. So could the provider not be an issue by the package?
Thank you very much. I can say both. What we experience, there are still those men who say, oh, fine, I enjoy being seen by a female nurse. But the majority of them were not comfortable. And now, as we scale up our men's clinics, we felt like, okay, fine. Also, there are those female nurses that don't have that attitude that can drive away men from coming to their services. Maybe let's try and see if they will be able to provide these men's services. But also ensuring that they incorporate the package that is now being implemented in the men's corners. So yeah, I can say both.
Thank you. Astrid Bernal-Rodoreda from University of Heidelberg. Thank you. Hang on, we can't hear you. Thank you very much for your presentation. I've got one specific question on the sustainability of the male clinics. Are they financed from foundations outside of Lesotho, or are they part of the package now, that of the interventions that's funded through the Ministry of Health? And one is a more general question. We've heard about all these different approaches: male clinics, mobile testing, home-based testing, disease, multi-disease booth. Has there been any comparative study as to what approach might work best for men, or is it context-specific? That's a question to the whole panel. Thank you.
Thank you very much. That's another issue that we are very much concerned of sustainability. This very good initiative, whether it will be sustained. I can tell you the answer is yes, it will be sustained. Because currently, the Ministry of Health is already recruiting male nurses that are paid from MOH budget.
Yeah. Right. Can we have maybe the last two questions for Thabiso, and then we take the general questions, starting with the gentleman who wanted to ask earlier on. Yeah, you can go ahead.
Sorry, no, mine was for the group. But I guess what I will say about this presentation is that it's just great for all these presentations for us to see these different models for men, because I feel we've really moved beyond, men jumping the queue so we can reach men. And I appreciated Megan's comment about having high quality services or attracting men not being at the expense of women, I think, which really devalues women's labor and time. So just to appreciate the program learning from this, I'll get in line for the next one.
Right.
Okay. Just wanted to hear from you if you have any data on the viral load suppression for these men that are receiving the services?
Thank you very much. Yes, we do have the data. Like now when we have these clinics established at those clinics, we already have men that already taking ART there. So once the clinics were established, they had to be transitioned from the main ART clinic to come now, also benefit from the men's clinic as a way of retaining them. I can tell you the viral suppression is very impressive, and close to 90 to 95%. Yeah, it ranges there.
Yeah. Can we have the gentleman who had asked a general question? And if there are one or two other general questions, can we quickly take them before we end the session?
I'm from South Africa. I really want to propose maybe to the networks as a first issue that we should maybe in the future plans think about regional strategies, because you can win in Lesotho, but your men work in South Africa. And they come and collect ARVs in South Africa, and I'm sure they are not registered in your centers.
Yeah.
We are losing a lot of money and budget in South Africa because of neighboring countries. People who come and collect treatment in South Africa and go back. So because the theme of this conference is building bridges and breaking the barriers. So we need to look at that. The other issue is affordability. I went to one of the men's clinics in South Africa. I have to walk out because I didn't have the kind of money they wanted from me to be tested. So affordability is one of the challenges that we need to look at. My general question was, having listened to all these presentations, targeting men, I didn't hear about the cultural challenges that could make men not to come forward. Can be from their religious background as well, Muslim, Hindu, Baha'i, and all the rest. Have you looked at things that can make men to be rigid to come forward to these services, to other cultural activities? The linkage between religiosity and cultural practices like Mabullo, Lesotho. You know, you call it winter schools. I don't know what you call that. Mabullo, you know, you'll come to that. How do you bring this, actually, these two together and blend them together, whether those initiation schools, you also tap into their potential to assist, to advance the education that you seek to achieve. Thank you very much.
Yeah. We are fast running out of time. I'll just ask the individuals who are standing to quickly ask your questions, and then the panel will try and respond to the question. So Laura, and then the ladies, the two ladies at the back, and finally the gentleman to my right.
Hi, thanks for all the presentations. I'm Laura Block from ICAP New York. I'm wondering, we've sort of heard varied results about male providers having any impact on male uptake of HIV testing and services. I'm kind of wondering, just across the panel, what evidence you saw, if any, that this has an impact on uptake.
Okay.
My question is really about adolescents, and looking at the data, you know, generally testing among adolescents can be very low yield testing. And so as we're looking for efficiencies in testing, I'm just curious about thinking around the value of testing as a primary prevention intervention, particularly for adolescents, and how do we account for that when we're trying to put together an efficient testing program, but one that's also going to have an impact. I think I saw in one of your slides, Michelle, that the proportion of first-time testers is always going to be much bigger in young people. And so how do we make sure that we're placing the right amount of value on that as part of an overall prevention portfolio?
Thank you for your presentations. I'm Daphne Williams with USAID Nigeria. My question is really for those of you who have identified the interaction with health workers as a primary barrier. Has there been any engagement, discussion with the various ministries about providing some kind of provider training, even in the schools as was just presented? Has there been any discussion about incorporating some of the friendly services into the provider trainings? Thank you.
Thank you. Sunny Sharma from Ipsos. In Megan's presentation, there was a verbatim from a 19-year-old guy in Chichen who says, the nurses should be treating us, but they're mistreating us. I think all of us in the room would agree that nurses go into the profession with the best intentions, But are there any insights into what is potentially driving that behavior in the first place?
I think we can leave it to the panel to try and answer the questions which have been posed. We can start from Tabiso.
Okay,
Come
thank you,
this way.
thank you very much. Actually, I'm very happy that you raised that question. Yes, we are very much aware that most of our men are now going to South Africa because now, Lesotho is much locked in South Africa and South Africa has got a lot of job opportunities. So one of the reasons that we have implemented these men's clinics is to ensure accessibility. And we are really much happy to tell you that actually the men's clinic initiative, we copied from South Africa because now we wanted to just to replicate it and make it more suitable to fit into our country. Also looking at, and the services that are provided in our men's clinic are free. And culture, yes, the cultural barriers are there. That's why we're looking at issues of initiation schools, Lebolo, like you said. We have service providers that are really from initiation school. So they are able to go and attend those men at initiation school. As we speak now, they are already having their outreach program. And also the good thing that we can tell you that to show that we are really addressing this issue. One of the men's champion that we have in country who's an advocate for men's corners is the principal chief. So he's able to disseminate the message to his local chiefs and ensure that everything is being well addressed. Thank you.
Yeah, Michelle?
One of the, is that on? Yeah. One of the things that has really impressed me in BCPP is the passion of the community-based providers who are employed through our implementing partners. I think they are people from the community who understand the cultural facilitators and cultural barriers, and they would do anything to help these people. They would work any hours, any holidays, weekends. So I don't know exactly what the answer is around all of the problems that we have with lack of friendliness of facility-based services. We'll see that coming out of the qualitative sub-study from this study as well. But I think there's something to be learned from these community-based providers that we really need to tap into.
Great, thank you. I know we're running short of time, so I'm just going to quickly sort of highlight what I think is kind of a response to the question of what do we know about how to deliver these services, the question about understanding the cultural barriers that are coming into play, and also even among healthcare workers. And that's to say, I think we need to understand a lot more about what's going on here. And I think that is both in terms of qualitative research and really understanding and kind of diving deep, and also doing some randomized trials about, comparing different components of, say, standalone clinics and male healthcare providers. So I think the kind of general thing is we need to understand more. But I do want to say, in particular to the healthcare workers, I think we make the assumption that men have to deliver services to men. And I think one of the most surprising things that came out of our small little study when we were trying to understand this is that, in fact, we have two female middle-aged women who are delivering services to these young men in these clinics, and the rapport they have is what makes it work. And they have somehow managed to overcome those barriers and treat these young men with respect and understand their needs. And I think it can be done, and it's somewhat a matter of training and also a matter of, giving the right kind of space and support for engaging with people on that level. So I guess I'll leave it at that for now.
Yeah, I would just add to that last comment to say that we did add male providers into our mobile clinics, but I think what's more impactful for men is providing a friendly space where they're not surrounded by women with children. The male providers didn't necessarily seem to make a big difference in terms of them accessing care. And the other comment I would make is that community sensitization and awareness campaigns, the importance can't be understated. It's important to work with the religious leaders or village leaders in the community who really are respected, to get them on board, to get them to buy in, and only they can really change the narrative around masculinity in these settings. And so working through them is critical to getting the males to uptake these services.
Yes, so I won't repeat what has been said, but regarding the cultural challenges, so we have not done that within our settings. but it's something we could consider doing FGDs to understand what barriers are so that we can improve uptake among men.
Great, so thank you very much. I'd like to thank again all the panel. I think we've had a really interesting group of talks that have taught us all a lot. Thank you to the audience for your great questions, and I hope we continue talking, but we finally just get on and do it and make sure we get all the men into the services they deserve. Thank you very much.